Live from New York. It's Thursday afternoon. This is Benefits with Friends. I'm your host, Lou Bernardi. Thank you for joining us today. May the 4th be with you for all your Star Wars fans out there. And I am going to bring into the show Allison De Paoli, and just coincidentally, a huge force in benefits on May the 4th. So welcome. How are you doing?
I'm great. Thanks for having me today.
Awesome. I planned that whole thing, like force. Anyway, so thanks again for being my guest on the show today. Today's show is all about employee benefits, actionable data that, you and I traded some emails. What should we talk about? Because we could talk about pretty much anything. And I really think that was a great suggestion, because I don't think that we've alluded to it on all the podcasts. A lot of what we're doing is based on the data we've been able to see for the last few years. So and I brought some slides in. I wanted to put up in a moment as we get through the conversation. But I wanted to give you an opportunity to introduce yourself. But first, I'm going to tell people who you are, and then you're going to add to it. So I know that you are the owner, principal of an agency. Isn't it San Antonio?
San Antonio.
Altiqe. You are multiple award winner in the benefits industry. YOUPowered, most innovative healthcare consultant 2022. Next Gen Benefits Advisor of the Year, same year. So you had a great 2022. Benefits Pro Magazine list of top women in advising 2019. And you are serving as chair of the South Texas Blood and Tissue Foundation, which is amazing, and on the board of Family Service Association and National Association of Benefits Insurance Professionals from San Antonio. Did I miss anything?
No, I think that's more than enough. I'm actually the immediate past chair of the South Texas Blood and Tissue Foundation, and that was a job near and dear to my heart. And I passed it on. They call me Rabble Rouser. And so I passed it on to Rabble Rouser number 2.
Awesome.
So they're in very good shape now.
That is terrific. So, again, thank you so much. We've met each other a few times through the years at various benefits conferences. We've gotten to know each other a little bit. Most recently, we were in San Antonio, actually.
We were.
And that was the GovCon Maximize 2023 GovCon conference. And that was a really good one. It was a little different, right? Because it wasn't totally benefits. It was kind of very niche specific thing that I'm hoping to get involved with here in New York. I think there's a lot of opportunity to help government contractors, but kind of back to data. And for me, I'm not going to ask you your age or how long you've been in the business, but I would share, I've been in the business for over 30 years. And, 2017, my entire approach to benefits changed after 26 years, or 25 at the time, I guess. And it was because of data, right? I was the expert, and I thought I sold insurance. I was great at renewals. I would get, down to the single digits every time without a tremendous amount of watering down benefits. And I never really knew why. I just thought I was fantastic. And, maybe to some extent I was under the old formula. But then sometime in 2016, I saw some data that I don't think I was meant to see. And it was the true price of healthcare, right? The true cost of medications versus what we're actually paying. And I think at the time, because I had left my GA career, I was really starting to question medical trend, just that idea of medical trend. And I didn't, from my finance background, I didn't understand why these huge health insurance companies weren't able to use their leverage to keep prices down. It didn't make any sense to me. So I think I really just started looking up medical trend. What is it? And I came across people on LinkedIn like Dave Chase from Health Rosetta and other people. And I didn't like what I saw. So I don't know if is that, and I know you're not a typical benefits broker, and I call myself Boo because I really want to be a benefit optimizer these days. Was data something that was really intricate, important and was there some sort of change to your career as a result of it, like mine?
Yes, but it was a little it was a two-part change. So I have been in the employee benefit space for about as long as you have. And my family owned a boutique firm in South Florida, and we pretty much only did self-funding for mid-sized employers, 200 or so to probably 3,500 or so. And, that was a long time ago. I mean, I've been in San Antonio for more than 20 years, so that was a long time ago. And we could see everything, right?
Mm-hmm.
And we could do anything, right? Like, you wanted to change this, you wanted to do this, you wanted to do this. We did all kinds of stuff. And the happiest group that we had was a group of 35 accountants, though. They thought self-funding was great. Those people understood it better than anybody else. And that was the best thing for them. And then I moved to San Antonio, and I moved into another part of the employee benefits space. And then about 15 years after that, I pivoted back into I worked with a carrier that did their level best to destroy my $1 million book of business. And I know it wasn't personal, but it certainly felt that way. I think we've all had that experience, and entered the enrollment space. So I'm just so not suited to that space. And thought, you know what? I have all these clients, and I could fix that problem, and I could fix that problem, and I could fix that problem. And thought, well, why don't I just go do that? Now, most of those clients were referrals from other brokers, and I didn't want to do the reputational damage. So I basically built a book from scratch, which is kind of hard, but I fixed a lot of those things. Now, I can't fix everything, but I can fix a lot. And I did that by getting people to vendors who have financial responsibility to the employer and not to their stockholders and not to each other, which is one of the biggest problems we have.
Yes, absolutely. So yeah, so that's very interesting. So you've seen the data, you've been exposed to it for a long time, and being a GA, I sold fully insured plans. I'd say probably most under 1,000 lives for the most part through the brokers that I worked with. I won't mention the GA or anything. And you got data. You got numbers. I don't even want to call it data. You got numbers, right? Very different. I'm going to pull a slide up in a second, but when you think about numbers versus data versus actionable data, there's numbers. That's a renewal, like a fully insured renewal. Gives you a lot of numbers. It just totals and percentages, and it's meant to be confusing, and it very often is. And I would say majority of the brokers who I was helping sell employee benefits weren't benefit experts. That's why they used someone like myself. Correct. And we accepted the numbers. We assumed, and you know what they say about assuming, but we assumed that the insurance carriers were getting discounts, right? Back in the day, they did. Somewhere over the last 25 years or so, they stopped trying, I would say, to get discounts. But then, there's data, and then there's actionable data. Data is just a lot of information that you could throw at someone, but it's useless, right? There's way too much. Maybe an example of that would be the some of the price transparency, like hospitals and insurance companies releasing data that is just, you can't even download it. It's so enormous. It's not user friendly at all. And then there's actionable data. I have somewhere here a definition of actionable data, and I would like to read what it is. The term actionable data is often used in contrast to big data. While big data refers to large sets of data that may be difficult to process and interpret, actionable data is a specific subset of that data that can be used to make decisions. And that, to me, was like the most monumental change when I was exposed to actually actionable data. And I saw how that we could use that. You knew it. I was already very comfortably into my 26-year career at the time. And I thought, this is what I'm going to do for the rest of my life. And when I saw the data, it wasn't just the data. It was how that data made me understand how the decisions that we had been helping employers make for the previous 20 years were harming their people. Yep. And I remembered, I've had over the years thousands of open enrollment meetings that I helped conduct, and literally hundreds of people cried on my shoulders over the years because I always offered to stay. Because for me, it's about the people. I love people, And I felt so great about going to open enrollment meetings. I finally get to serve, see the people that I help all year long. And I realized I was the Grim Reaper. I wasn't a superhero to them. I was the guy who always delivered pay more, get less results. And that was really hard for me to live with. And then I realized the reality of what we were doing and how changing a copay by $20 doesn't seem like a lot, but for some people, that's a lot of money.
Do you talk about how actuarial value impacts a health plan and how that has little to nothing to do with the cost of care?
No, I wouldn't say so. Elaborate on that.
So I've sat in, I do some consulting in addition to brokering business for our clients, and I've sat in a number of consulting meetings where I'm the consultant and I'm not the broker, and I've worked with a number of brokers that come out of the actuarial side, and I've literally seen them sit in front of a renewal and employers say, well, it's too much and it's this and it's that, and literally watch them calculate how they could change a copay or a deductible, or maybe just an ER copay.
I know what you're saying.
Maybe just a physician, or maybe just a prescription copay, and maybe tweak the max out of pocket just a little bit and get 2 or 3 percentage points of actuarial value out of that, drop the employer premium to where they want it to be. But really the only thing you've done is irritate employees.
Yes. I understand what you're saying now. Yeah. So there was a company, oh, wow, I really wish I could remember their name, that had some really, for me, very impressive software. And I subscribed to it a few years ago. And you could plug in changes based on actual claims. And, so for example, changing a copay from $10 to $20 or 20 to 30, whatever, you get a decrement, right? You get some rate relief on a fully insured plan. But what is the impact on the members? How many of those copays are going to be utilized, right? Is there value in making that change? What's kind of the reward and what's the break even? All of that stuff.
Correct.
Yeah, exactly. Yeah, I see what you're saying.
The premium cost, but you're not really changing the cost of care. And if you're not addressing the cost of care, you're never going to change the premium equation.
Well, that's the thing, is right. So when you're focused exclusively on premiums, which most employers are, right? Unless you're self-insured, you're almost entirely, just waiting on standby to get a renewal delivered to you. I'm gonna pull up a screen actually here. Let's see if I can pull up the right one, just to give an idea. Now this is a live show. There'll be a video version. There'll be a podcast where that will be a little bit harder to see for people, but we can talk. Let me see. Where's my share screen? Wow. I don't know how to do it. Let's see. Share screen, and there we go. Okay. So here's you're kind of talking about just data, right? So here's a renewal. I took out the name of the client, their policy number and everything. And there's a renewal from back in April of 2021, fully insured group. This group has, I think, about 220 employees, maybe a total of a little under 400 total members on the plan. And this is what you get from your insurance company. If you're experience rated and you're fully insured, right? You're going to get the prior 12 months versus the most recent 12 months, total medical cost, total RX incurred claims. And this particular group, they have a lot of claims, but this is completely useless. This is, for me, and I've spoken, I know a longtime ex-underwriter of United Healthcare. He was the lead underwriter. He called himself the chief revenue officer, because it's all BS. None of these numbers mean anything. It's not that the medical claims and the pharmacy claim isn't accurate, but none of the other numbers that I put here in green, well, the pool claims is a real number, but the trend factor, the claim pool weighting, retention. I compared 4 different renewals, similar size groups from the same month, and none of the numbers were the same. Right. The numbers that the insurance carriers work. The only number that's important for them is this bottom number. They wanted to start at 16.3 here. So they work backward. They work backwards, the underwriters. And depending on the broker and how sophisticated the broker is, or how difficult the broker can be, that number is going to change. So if they know that you negotiate really, really, really hard and you come back 6 times, that would start with maybe 25% for someone like you and I potentially,
Right.
instead of 16, because they know you're going to get them down to a certain number, and they want to paint that picture. But this isn't data. This is just justifying a renewal. And they start at 16.3, and the underwriter has certain flexibility, and they know that if you get it down to 7%, that feels like a win. Right?
Even though it's really a win for the insurance company. And
it's a win for the insurance company. And that same underwriter that I spoke about, I won't mention his name, has shared with me their biggest losers as far as loss ratio clients can be their biggest winners in revenue. Not necessarily for the insurance side of the company, but if you think about United Healthcare, that the United Group umbrella that includes Optum RX and Optum Analytics and the Optum Health division, with I think the largest. They're the employer of more nurses in this country than anybody else,
and doctors,
and crazy, and doctors, right? They're getting into the medical side of things. Why isn't the profits under the controlled group of companies actually taken into consideration? What is the actual loss ratio for this group for United?
Correct.
Right? Or the Optum, the United Group of companies. So I wanted to focus on the pharmacy for a second. $966,482 in RX claims in a 12-month period. This is a company with 249 subscribers. $1 million in RX funds in 2021.
Oh my gosh.
Right? Actually, 2019 to 20. So this was even partially overlapping with the start of COVID, right? March of 2020. So it could have been worse, potentially. There people couldn't even get into the doctors in some cases, right? So now I'm going to share another screen with you. I think I have to stop sharing that one. And I wanted to give a glimpse of what share screen, what I would call actionable data. Not the same group. Okay.
There we go.
Right. And this is for the consumer, right? We're having a conversation, but I'm hoping HR people, CEOs, CFOs see this. This is actionable data. This is a slightly smaller company. This is a company, I took all the member information and client information, but this is claims data, actionable data on a prescription spend that we get. Now, this particular client that was with Aetna, self-insured client, and we were the broker when they were self-insured with Aetna. And it took us a couple of years to convince them to move from Aetna to an independent TPA. And you mentioned control and change things, right? We needed to make that transition so that we could have control over the plan document, partner with an independent TPA that has an aligned incentive with, they're making money for providing a lot of value, the value that people probably think they're getting from their insurance carrier, but they're really not. Not worried about their stock price and their shareholders' pressure, right? But this particular group, I think they have about 220 employees. I mean, this is alarming. People haven't seen this, but not a huge company. They had 2,370 approximately scripts over a 12-month period. That's a lot of scripts.
Oh my gosh.
That's a lot of prescriptions. This is not unusual though. Now this particular group, this is the number, let's just say here, paid claims, plan paid, $302,000. Now that would be the number that would have been on another exhibit we just looked at, paid claims, right? $302,000. This is the year after we moved them to an independent TPA. The prior year, their claims were $600,000 with Aetna in pharmacy. And we saw that, and we were able to get, because they were self-insured. Now they were with a company, but they were self-insured, so we could get the data. It wasn't being shared with us regularly. It took several weeks to get the data, but they finally did give it to us. $600,000 worth of claims spend, and we gave it to a couple of independent TPAs, which I'm sure, you have your preferred vendors in that world.
You have yours. Yep.
And gave it to them, and they estimated that they could bring the cost down about 54%. And then they showed us why. So we were like, well, that's a really big number. We'd be happy with 30% or even 10, right? Wouldn't you want to save 10%? But lo and behold, the year one result was a 50% reduction. We did not change the copays. We did not change the plan design. We didn't change the medical plan design. But what's really interesting is that they had one member who was there was a perennial large claimant, $600,000 a year just for the one member, and there was a laser on this person, so they had a $600,000 deductible for that one member, so that their stop loss collectively for the whole group wouldn't. I mean, you can't hide that, right? So if you don't have the laser, you're just paying higher stop loss premium. So why do that? That member's claims dropped from $600,000 to $180,000.
Oh my gosh!
Right, because what we found out is that person was on a medication that shouldn't be covered at all. It's free if you don't have insurance for it. I wouldn't have known that, right? I mean, could you? So having actionable data, and I'll stop the screen share now, but just kind of get back to the conversation. But I wanted to give people a glimpse of what, not just talk about data. This is what the data is. This report gives you the cost of the medication, what they paid for the medication, the member's copay for the medication, how many pills, how many refills, how many months, how many members, all of that stuff. When you have that data, we're not giving that data to the employer. We're sharing the data with the employer, but we're not giving it to the employer to say, here, do something with it.
Correct.
Right.
We're going to do something.
That's the difference. That's why, someone like yourself that understands why data is so crucial, because isn't it about making informed decisions instead of just throwing a copay change out at a group?
Exactly, which is my point. A copay change may get you where you want premium wise, but it's not going to help you in any other way, and it's just going to irritate people. And I think if you can arm people with information, people will respond in their economic interest. We changed one of our clients from PBM-A to PBM-B in 2023. And I had two experiences like the second week in January. And the first one, I got a call, and it was, I just picked up my prescriptions and something's wrong. And I thought, oh, not already. No. And I said, okay, it's somebody I know well. And I said, okay, what's wrong? She said, I picked up my 4 prescriptions. Okay. I paid $23. Okay. She said, I didn't pay that before. Okay. What'd you pay? 80 something. I said, I'm not seeing the problem. And she said, something's wrong. This cannot be accurate. I said, did you pay? Did you give them your credit card? Yes. Did they give it back with the prescriptions? Yes. I said, you're good.
Yeah.
And it was generic, it was all generic medication. And the result for that family, which is a middle income, not senior management, middle, little higher middle management.
Yeah.
The result for that family is that she now gets a 90-day fill rather than a 30-day fill. And it's more convenient for her. And actually the 90-day fills don't cost $60. They cost less than $60.
Wow.
So that's actionable for them, right? I had another member call me and say, I'm trying to fill my Singulair and it's $49. I said, Singulair or generic? She said, generic. So I'm tapping on my phone. I said, are you at Walgreens? And she said, yeah. How'd you know? I said, it's the most expensive place to fill that drug. If you would like to go to Walmart, HEB, which is a local retailer, or Costco, it's between $4.40 and $7. And she literally swore at me, not at me. She didn't believe me. And she took it next door to one of those places. And she's like, I didn't believe you. And you were right. It is amazing what people can do when you give. And again, $49 to about 5 is meaningful for many people.
Absolutely. I'm so glad you brought that up because I'm sure I'm not going to speak for you, but I'll tell you, we don't do what we're doing today because it's easy. And we also
It's
don't
harder.
do what we're doing today to save companies money.
Mm-hmm.
I know that we're able to do it because we're likely to save companies money. All right. But they're going to give us the okay. But the approach that we're taking is about making using the money that you're making to invest in your people work for your people.
Mm-hmm.
If a company is paying $4 million a year in premium, that group I first showed that had about 250 employees on the plan, they're in 2021 their premium was $4 million a year, of which $1 million was medication. They have no idea. They think they're using, because they're using the largest insurance company in the country,
They're
they
getting the
must be
best
getting the
deal.
best prices and the biggest discounts. But they're not. They're not getting that, right? So those companies are using their leverage to maximize profits.
Mm-hmm.
They have to at least give the impression that they're working in the best interest of their people, right? But the reality is they're not. And you can't hide the facts. When you have the power and I call what you just described CQI, constant quality improvement, right? The first PBM, by the way, for you guys out there that might not know, it's a pharmacy benefit manager. Every insurance company out there has their preferred pharmacy benefit manager that usually they own or are owned by. Right?
Correct.
I like to. This might be a Texas term. They're in cahoots with each other, right?
Yes.
They're working.
And there are very good reasons that CVS bought Aetna and not the other way around.
Absolutely right. So now, what you're also not saying is that the cost of healthcare and the cost of prescription medications is not the same with the same insurance company every place you go.
Correct.
They have different deals with different vendors like Costco and Walgreens and CVS and Walmart drugs. All of these places have different deals with these insurance companies because they're in partnership. They want to get people in the door, filling prescriptions, getting medication, driving people not to where the quality or the cost is beneficial for the member. It's where it's beneficial for them and their deep pockets.
Correct.
And that's what the data shows. And it's really hard to see this data for the first time. I completely get it. I'm typically the first advisor that's sitting down with an employer to have this really ugly conversation. They've been groomed partially by benefit brokers like myself over the years who were selling an insurance product that was it wasn't a great product. There wasn't a lot of value, but it was simple. Here's your premium today. This is what it's going to go up if I tweak these copays. It's simple. It's like arithmetic versus multivariable calculus, which when my son, who's now a rocket scientist, was taking that in college. I looked at it and I said, when did they stop putting numbers in math? I don't get it. What is that? But anyway, that's the difference that we're talking.
Correct.
At the end of the day, the impact on the members could be amazing. That friend of yours who, said there's a problem because they saved money. That's so unfortunate because that should be happening every single day.
And I think it says a lot that she thought that there was something wrong. She was certain there was something wrong. And she's a pretty good consumer. She's a pretty good advocate and a pretty good consumer. Mm-hmm. And she's not, she's a user of care. She's a regular user of care. So she understands how to navigate the system, right? So for her to say there's something wrong, one, I pay attention when she tells me that because she's normally right. But it was, I don't want to say it was heartbreaking. That's too intense an emotion, but it was sad to me that for her to pay, she thought that there was something wrong because she paid less.
Right. And the fact that, the show, one of the, the title of the show is, the kind of the awakening of the American healthcare consumer. Mm-hmm. And that's what people are, right? But we haven't been able to be consumers of healthcare or health insurance really because we haven't seen anything. We're just kind of going along with the flow. And we're going to pay more, we're going to get less every single year. That's just the way it is. Let's move on. And businesses have thrown in the white flat towel because it's not worth their time to fight this fight. But now you show them the data. You gotta knock down the door to be able to say, listen to me. Listen to me. This $966,000 in prescription claims is really probably $450,000.
Mm-hmm. And they're amazed and they're sure that you're doing something illegal. And then they get very angry.
They get very angry. And what they should be is angry that the regulators, now there's Department of Justice is right now, has all of the biggest PBMs in the country, those pharmacy benefit managers, in the hot seat. Mm-hmm. And maybe there'll be some legislation to come out of that potentially. But let's talk. So we, because pharmacy is an easy one to really kind of share the data. When you described your friend and client who was used to paying $80-something for generic medications, and now it's $40-something. There's a couple things going on there, and you tell me if I'm right. It was the spread pricing by the insurance carrier. So these might be medications that are, let's just say, $5 each, but they were being charged
a differential,
$20 each for these medications. That's a spread. Now, your insurance carrier doesn't tell you this, but they don't typically. If you look, I don't know if they were self-insured before, but if they're self-insured before, most of the PBMs will charge a per script fee. Mm-hmm. A lot of the BUCA, the healthcare owned PBMs that partner with the insurance carrier self-insurance divisions, they don't charge a fee.
They don't
and
have
that sounds great. Oh, there's no fee. But where are they making their money? They're making their money on that spread price. So your friend who may have been paying $80-something, I don't know if that was her cost.
That was her cost. So they have what I think is a great plan. They used to have a $4,000 deductible 100% plan. And as an insurance person, I look at that and I think that's fantastic. The people hate that because they don't know what their drugs cost. They don't know what their office visit is going to cost, and they have to pay that out of their pocket. So the people that are healthy don't get care. They don't get their regular checkup. Well, they can, but they don't. And they don't do their regular stuff because they don't know what it's going to cost. And we haven't had tools to help people be good consumers. Now, as we've saved this employer money, they actually have not reduced their healthcare budget. They have reinvested that back into their workforce. One year, they cut their deductible in half, and they cut their premium contribution for their employees by about 25%.
Wow.
And they added a long-term disability benefit. They did that with the money that we found from helping them pay a fair price for healthcare.
Right. They just reinvested the waste in their plan.
Correct.
Artificial prices. I call artificial prices, hidden profits that right now are being steered elsewhere. Come back to the employer. And what could you do with that? Right? Bonuses. More benefits. Invest in your company. Invest in technology for your company. Get your company to be the employer of choice, more competitive in the marketplace. There's so much that can be done with that money that's saved. Right? $400,000 might not be a lot of savings for this company that's a billion-dollar company. But not doing something is taking its toll on its employees.
Correct.
Because they still look at this health insurance budget that they have now, and their C-suite, their financial people are saying, well, we've budgeted 5%, we've budgeted 8%. You need to get down to that number. And not having access to the data forces that insurance decision of, well, we got to 12%, we got to find another 4 somewhere. So show me options, which means cost shifting to the employees. There's only one way there's only 2 ways you can make up the 4%. Make your employees' contribution higher, or increase their out-of-pocket costs.
Correct.
Right, which just really contributes more to care avoidance, unhealthier population and higher claims in the future.
Correct. And I think employers are often focused on the biggest discount for office visits and things like that. Honestly, let people go to the doctor where they want to go to the doctor. Just get them to the doctor. And if you worry about what the knee replacement costs and the back surgery costs and the chemo costs, then you will control your costs. And
Right.
there are ways to do that positively impact the employee as well as the employer's budget. And, we've been very fortunate. Our clients, for the most part, are very aware that their employees are patients when they are interacting with the healthcare system.
Mhm.
Not every employer can or does. So there's real conversations about how this impacts employees.
Well, when you have the insights, like I showed the pharmacy, but when you have access to the medical claims,
Mhm,
right? And now you actually have the diagnosis, you have the procedure codes, you
mhm,
see where people are going, you can
mhm.
see the cost of radiology, you can see the cost of ER, you can see why they're going to the ER. Should they be going to the ER? Maybe there's a gap in the benefit where they haven't educated their employees enough to make them understand, well, maybe urgent care is more appropriate for that condition, right? Or
Correct.
that particular visit. Maybe the employees need a primary care doctor. We all know that there's such a shortage of primary care
Mhm.
doctors. So people, that data on the medical end can show what percentage of your employees actually had their routine physical in the past 3 years. Forget about year.
Correct.
It's
And the other thing that it shows is what claims are paid on a CPT code and what claims are paid on a DRG code.
Mhm.
For those of you that are listening, a DRG is a group code and a CPT is a specific service code. So I think the easiest example for that is there's a DRG code for emergency room visits. There are typically 5 levels of emergency room visit, 1, 2, 3, 4, 5. If something is billed on a DRG code rather than a CPT code, then as long as the price is within the discounted range of the DRG group, the claim will be paid. So what that means is you could conceivably have an emergency room visit that was a level 1 or a level 2 bill at a level 5, and nobody will look at that because of the way claims are auto adjudicated, right?
which I had a guest on. Well, let me let you finish if you had more. Go on there.
So we had a client that we did a claims analysis for, and they were a large client. They had about 2,300 on their plan. They had $18 million in billed claims. That's not what gets paid.
Right.
Billed claims. Over $6 million of that was paid on DRG.
Wow.
So if you're a manufacturer or you take delivery of something, it's like taking an unverified delivery,
And
right?
most of those claims aren't itemized
They are not
at
itemized. So
all.
you have no idea what's happening. We had another person, a chemo claim about 19 visits, and the notes say dosage specific to the individual. Please check the notes for dosage. And there were no notes in the dosage, yet the claim was paid every time. So conceivably, you have no idea what was delivered into your member's person.
Wow.
So those are problematic on many fronts, right?
Yeah. Well, I had a guest on, 2 guests on, a few, shows ago from Slingshot Bills,
Mm-hmm.
and 2 brilliant, um, graduates of Georgia Tech. My son went to Georgia Tech. They graduated. They didn't know each other, but they graduated the same year. So I got on a call with them, and I was blown away because here's 2 young, mid-20, um, engineers who had great jobs at really big, global companies.
Mm-hmm.
And Zoe, Holderness, had gotten a bill. It was her first experience as an adult. She gets, she goes to the doctor, she gets a bill, and she's like, what is this? Like, she's a numbers person, right? So she looks at it and she starts doing research and blah blah blah. And before you know it, she's fighting her claim, and she sees that upcoding that you referred to. She
Yep.
was looking at the codes, the procedure code, the diagnosis code. She's like, I wasn't there for anything like that.
Yep.
I went in, I got a Band-Aid, and I left.
Uh-huh.
It seemed as though by the description that level
Her arm
5
was cut off.
description, that she walked out of there with losing a limb,
Yep.
essentially. It was a ridiculous bill in the thousands of dollars, and she had a high deductible plan, so it was worth her time to fight it, and she had the intellectual ability to do it. So then she started talking to friends, and she was helping them and their families. So they built a company called Slingshot, which basically is a add-on to a self-insured plan. They work in conjunction with the TPAs, and all of the codes run through their system, and they identify the up codes and the unbundled bundles. So certain things where when you go into the hospital and you have a procedure, a certain type of surgery, well, there's a bundled rate for that a lot of the times. Yet the facilities unbundle it, and they're charging all of these things, right? So again, as you mentioned, this universal claim form goes in. It's like a summary claim form. It doesn't even care. It's not their money, so why should anybody hassle it, right? They're going to pay. Right. And they found that 60% of claims that they analyzed had upcoding. So 60% of the claims. I said, you're wrong.
I'm not surprised at all.
I said, you're wrong. It's 99%. There's a flaw in your math. There's no, because it's business, right? People don't realize a few years ago, maybe I'm going to guess eight years ago or so, there was a huge dramatic change in the medical coding world. And the codes were multiplied by like 10 times more than there were in the past. And that made way for all of these different levels of codes. When you go to the doctor, you're not just at the doctor, you're a code.
Yep.
And he on average, they spend 7 minutes with you, but they could bill for something that may have made it seem like they spent 45 minutes with you. It was very involved. And they're trying to get as much money, especially now that more and more primary care doctors and specialists work for the health systems. They're not doing their own billing.
And I think the other thing that's surprising is that doctors have quotas on the amount of referrals they need to do and on the amount of services that they need to provide. They're called RVUs. And I think that's appalling for the doctors and appalling for the patients. And the other thing that happens is typically if I'm a doctor and I work in a hospital system, I'm only allowed to refer within my system if that's the right doctor for the patient or not. And that happened to my mom, and she's my mother. I can use her story. And she was referred to a cardiologist with a quality score of 27.8. Now, I'm fortunate enough to have the resource to figure out if the doctor is a high quality provider or not. But if I'm a regular person, would I even know to do that it was possible?
No, you would Google it and you might see that, oh, this doctor has a great bedside manner. The office is clean. The office people are friendly, which could be the case. But there might be a lot of different reasons why that doctor is underperforming, but it shouldn't be important to the patient. The only thing that should be important to the patient, and in this day and age of internet and technology and Amazon, where you can shop for anything within 2 minutes, you could find the best price, the quickest delivery, the highest quality, the lowest delivery fee. Heck, when I shop for something, Rakuten pops up and says, here's 15 different codes, and this is the best code for you. But you can't do that for healthcare. Why shouldn't you be able to? I'm a health reset advisor, and they recently shared some information with us that 20% of new diagnosis cases are misdiagnosed. 20%. Now, they might not have cancer at all, or maybe they have the wrong cancer, which for me is even scarier, that you actually have cancer, but they're treating the wrong cancer and wasting all of that valuable time, right? 67% of spinal fusions are unnecessary.
Have you ever heard our friend Al Lewis talk about spinal fusions?
Yes. Share though, because he's too smart for me.
Yeah, he's too smart for me too. But he says that the number one predictor of a spinal fusion is a spinal fusion.
Yeah. And 90% of spine doctors wouldn't have spine surgery. Right. It's just, but they'll do them all day long because they can, because it's very lucrative, My mom, you mentioned your mom. My mom's had 3 spinal fusions.
Oh,
The third one was to remove the first 2 because they were done at separate times and left her with a reverse arch in her back that was excruciatingly painful, and she couldn't sit up, and it was deteriorating all of this other parts of her body. And
yeah.
it took her about 2 years to find a doctor that would actually redo the work of the first 2. But it was, she and she almost didn't make it out. And it's very, 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 very sad. But actionable data is incredibly powerful. The scope of what it can help us as advisors do is amazing, but it can be put down. So you mentioned that you have access to a tremendous amount of data. If you're partnered with the right, or if you build, unbundle and rebundle a health plan the way I know you do, right? We're picking best in class solutions. It's very important they work together, that they're seamless, that it feels just as cohesive as that fully insured plan or that health insurance company. People don't realize if they have Aetna or they have United Healthcare or Cigna, they don't have Aetna, United Healthcare, or Cigna exclusively. They have 30 different pieces that those carriers have cherry picked, mostly because of profits. Again, they're not providing that value to the members. Shouldn't a health insurance company has all the data in the world? They've always had it. It's not new to them. They could have been helping people get to the highest value care, meaning the best quality at a fair price. All along before someone goes. We had a member, I talk about this particular case all along, and it was my first experience after we had successfully taken a client into this new, world of benefits that we're in. And I wasn't even a week or 2 into it, and I got a similar phone call as you did, but it was big for me. It was a member who was being prescribed a medication. At the time, it was the PBM reaching out to me, asking me who this member was, because to them it was just an ID number, and asking me to please reach out to the client to let the member know to expect a phone call from our PBM partner, because they're going to start an injectable medication. So now it's an injectable. It's going to be done in a doctor's office. This is not a pharmacy claim. This is a medical claim because of where it's being done. And it's $115,000 shot twice a year. So $230,000 is the price. Based on their best data, the insurance carrier was going to pay about $80,000 for the shot. So it's $160,000. That doesn't get me too excited. It's a lot of money, but it is what it is. But when I look into it a little bit further, and we have a company called OptiMed, which is an injectable medication and specialty med provider. They're sitting in the background. We're sharing the data with them. Again, it's just a data feed that comes through them. Pre-certification comes in through the network that we're renting, and it triggers them. They come back to us and say, okay, Lou, here's the deal. It's a medical claim. If this person, who turns out to be a 29-year-old young man who's on disability with 2 young children, single dad of 2, if he goes to the doctor's office, it's going to cost him $7,500 because it's going to apply towards his deductible and his coinsurance. And that's the way it would have happened for the prior 25 years of my career, because it always happens after the fact. You go get the shot and you find out 3 weeks later when you get the bill or the EOB. But instead, can you let him know that we can instead offer to him, and we're not mandating it, we would like to potentially, but we still want to give people choices. We want to use positive incentives based on the data to get people to change their habits. We're going to reach out to him and let him know if he agrees to utilize our source of the medication that will be done in his home by a registered nurse or nurse practitioner that's going to come to his home, it will cost him nothing.
Yep.
Okay, great. For me, that's what matters. $7,500 for this young man with 2 children. I know that's meaningful. Yep. Unless he won the lottery, this is meaningful. But we are also going to save the plan $100,000, because instead of $80,000 a shot, they source it, administer it, deliver it, and make their piece on it for $30,000 each shot.
I think that last thing that you said there is very important. That they make their piece on it. Business is business and it's here to be profitable. But we have a saying in Texas, pigs get fat and hogs get slaughtered.
Yeah.
So it's all right to make money, but to be egregious on the back of others, it may be the American way, but maybe we don't need to do that all the time because OptiMed makes plenty of money.
You can bring value and make money at the same time, but shouldn't you make money based on the value you're providing? I think what most bothers me about the current state of healthcare and health insurance is that there's no hiding the fact that the consumer has been deliberately kept in the dark. And if they hadn't been deliberately kept in the dark, we wouldn't be where we are today, where we're looking at $3,000 family rates on a fully insured small group plan in New York, right?
Mm-hmm.
$1,200 a single for a gold plan. We're not even talking about the highest level plans. And in New York, we're community rated up to 100 employees.
Right.
So you can't do stop loss, right? What's nice about the data is the data has actually helped us develop strategies and solutions for those small groups. Mm-hmm. Right? I can't change the premium. The premium's the premium. If you're in New York City and you're buying insurance on June 1st, your second quarter 2023 small group, it is what it is. But I can help an employer better use that money, appropriately insure their employees. I don't know if you thought about this. I'm sure you probably have. And again, it's about the data. Is that, because there's no access to information, most employers are really over-insuring their employees.
Correct.
They're thinking about, I got to keep the copays and deductibles and out-of-pocket costs so low because there might be a few people that actually use that. But what we're trying to convince people, and an HRA is a good potential strategy for small group employers, is buy a less rich plan and use that premium savings to reimburse or refund your employees for healthcare, but not just any healthcare. Let's couple that. Yeah, let's couple that with navigation. Just because you're fully insured doesn't mean that you can't, build a high performance health plan to the best of your ability, and most importantly, get your people to the best doctors. And there's a really great company. I love plugging some of the vendors. There's a company called Garner. Mm-hmm. I don't know if you're familiar with Garner, but
yes, they do very good work.
It's different, right? But you have to understand the data to understand the value of a company, like that. So anyway, we are coming up on the hour. I don't know if there's anything that we didn't touch on that you wanted to discuss. Is there anything that you guys are doing with the data that we didn't really kind of get a chance to mention?
I think it's really important to convey to employers, and I think you just did this when you talked about Garner Health, that even if it is in your best interest or your only option to remain fully insured, it doesn't mean that you can't understand what's happening so that you can negotiate, or somebody like you can negotiate a better renewal, and you can understand what your options are and make them work in a way that works for both your budget and as the employer and what employees need. So I don't care if you're a group of 2 or you're a group of 1,000, if you're fully insured, self-insured, level funded, whatever it is, you can get data in 2023 and you can get actionable data and you can make better decisions.
Right.
You just need somebody willing to walk the walk with you.
Well, that is the thing. And, just on that point, there are companies out there, technology companies, because technology seems to cause a lot of problems, but it can solve them too if it's used right. There's companies that can help us with claims harvesting.
Yep. And that's what you need.
And that's what you need so that you can make an informed decision, even on a fully insured group. It's a little bit of work to get it. Right? You got to, but isn't it worth it? If you can see inside that health plan and make sure that investment, that huge investment, I did an analysis recently, a 50-person group here in New York with a gold plan, it's about $1 million a year in premium, 30 singles, 5 couples, 5 parent children, and 10 families. It's $1 million investment that company, those are real New York small group rates. If you make double that, 100-person group could still be in the small group market. And that's a $2 million investment. Don't you want to make sure you're making that investment for the benefit of your employees?
And we are in a different healthcare cost market than you are, and that is a regional thing. But we have a group of about 150. Their claims and their plan administration does not cost $1 million.
Yeah.
And that's mostly singles, but there's some families and some spouses and some, employee kid. There's that whole good mix there. They do not spend $1 million a year. And now we worked really hard to make sure they don't, but they do not.
Well, it's just about wanting to be an informed consumer.
Mm-hmm.
There's no one that likes what they're paying for healthcare and insurance today. Zero. But what we're trying to do, and I'm sure you are as well, find people that actually will roll up their sleeves and work with you to do something about it. That's what it comes down to, right? You can help anybody, and you would help anybody, because I know what an amazing person you are. So it's great. Thank you so much for spending time with me today. Your email is up there, so that is great. Definitely, especially if you're on the West Coast, reach out to Allison. One of the things, this collaboration that advisors like you and I are doing, is that there's people like us throughout the entire country. There's some great people in every market imaginable. So if we can't help you,
we know somebody who can.
We know someone who can, who's an expert in that area. It can be very local healthcare. The problems are universal that we're all talking about. And anyway, thank you so much. This will be out on our podcast soon, be on our video showcase page, and hope to see you at an upcoming conference.
Thanks for having me, and I'll see you soon.
You got it. Thank you. Take care.
Bye-bye.
Bye-bye.